fine. I mean, you've described it now. So in your normal practice, is there any one sequence you would always like to have when thinking about a bone lesion?
Um, Post contrast.
Well, we'll come to contrast. I mean, but this is which
Okay.
these two axial and coronal images. Which sequence is that?
Sorry.
I mean, can you identify which sequences I've given you there? These two.
The axial and the coronal images of
Yes.
T1.
Yes, exactly. So these are T1
Uh,
weighted because you can see the
T1
marrow
weighted
fat.
images.
Right?
Yeah.
Okay. So what do you can you describe the T1 signal abnormality then?
It's slightly hyper intense on T1. Uh,
Okay.
yeah, the lesion is slightly bright on T1.
Right. Okay. What about the T2 weighted image there? That's the axial T.
Bright on T2 as well.
Okay. Okay, let's go forward then. So this is pre-contrast. You guys can see my cursor?
Yeah.
All right. So this is T1 fat suppressed pre-contrast. This is post-contrast. And these are diffusion weighted images, DWI and ADC.
Yeah.
Describe what you see and then let's close the differential diagnosis then.
Uh, so I think it's showing central diffusion restriction. Uh, and on the post contrast sequences, there is peripheral post contrast enhancement.
Uh, okay. Right. I mean, the lesion is there. It's an intramedullary lesion, isn't
Yeah,
it?
yeah.
All right. Okay. So that's the post contrast.
Maybe it's
And
not
then,
showing any
oh,
post contrast enhancement.
I mean, yeah, I mean, I should have shown you
Yeah.
probably a corona to make it. But if we go back, let's say we go back to this, do you think it's a cyst on T1 or
Uh,
difficult? Right. Okay. All right. But diffusion restriction, what does that imply?
uh, that it is highly cellular.
Right. So which cellular things you can think of?
Uh, some malignancy or
Okay. Which
let's
malignancy? Which two malignancies you will be
lip,
thinking about?
even I'm thinking of LCH as the patient as a child. Uh,
Wait, I missed that. Say it again.
uh, uh, LCH, Langerhans histiocytosis,
Okay.
or second, I'm thinking of lymphoma. However, the age group is less, and Mets.
What about infection?
Uh, yeah, yeah, infections can also restrict,
Right. Okay. So can you summarize
but
your
they are
finding?
low. But the infections are probably low on T1. It's slightly of higher signal intensity.
Is it an aggressive process or a benign process?
Um, so the edema is so much. I'm thinking, and the periosteal reaction. I think it's aggressive.
Good. Good. Yeah.
Mm.
So the differential, yeah. I mean, so okay. Next thing. So what will be the next thing to do then?
Uh,
How can we solve this case then?
so maybe we'll refer the patient for biopsy to refer the
Yeah.
patient for biopsy.
Refer the patient to where?
A sarcoma center.
Yeah. Okay. Yeah. Good. So yeah, I mean, this is an aggressive process. I mean, yeah, I mean, the way the you can say that it's primarily a diaphyseal lesion. I mean, the key
Yeah,
thing is when you describe a bone lesion, you need to where it is, which bone it is, which
diaphysis.
part of the bone it is. Yeah, you said it. I mean, during the description, but that's the key thing. We've
Yes.
got a lytic lesion, or we got a lucent lesion in the mid diaphysis of the left fibula with reactive periosteal reaction, with periosteal response or periosteal reaction. On the MR, there is a lot of juxtaosseous edema. Okay, it's like bone in bone. I mean, this is the bone. You see, this is the fibula, and they think this is all kind of periosteal reaction around it. Okay, so yeah, it was. I mean, the child was well, but obviously, I mean, infection. You can have low grade infection, or you can have tumor. So whenever the tumor and infection, they always interplay. I mean, on imaging, sometimes if you see a large extraosseous soft tissue mass, then you think it's tumor. If you see abscesses or the child is unwell with fever and things like that, then you think about infection. But when you are in doubt, you always have to do biopsy. So yeah, it was biopsied. It came back as LCH. All right. Okay, let's just move on. What about this one? This is a 16-year-old, and he
Mm.
has got right thigh pain.
Sir, I'm provided with the radiograph hip, and I could appreciate lesion partly visualized in the shaft of the femur with significant uh, periosteal reaction, giving sunburst appearance and cortical thickening. However, I would like a dedicated view. I'm thinking of
Uh,
some malignant process, or I would
what do
like
you see
to.
here? Can you describe what you see?
I'm seeing a ill-defined lesion in the shaft of right femur with significant thickening, cortical thickening, and periosteal reaction, giving sunburst type appearance.
Okay. I mean, it's projecting a bit, probably not that well, but let's see. Can you see it now, or can you describe it more? It's a bit bright image,
Yes,
so my apologies for that, but you can see the whole thing now.
yes. Um, I could appreciate ill-defined sclerosis involving the mid shaft of the femur. Uh, the cortex appeared thickening. It is involving the diaphyseal region. There is surrounding soft tissue component. Uh, so I'm thinking of some malignant process like Ewing and osteosarcoma. I would like to further evaluate the patient with MR and then send him.
Okay. If I show you the next image, yeah. So does that add to anything? Do you still
Yes,
kind of
I'm still
stay with
thinking
your?
it of as a aggressive lesion because the periosteal reaction is like
So
cord.
let's say this is osteosarcoma. So what type of osteosarcoma you can
Uh, it
classify
could
it?
be parosteal osteosarc.
Is it a typical location for parosteo?
No, I think it's in the
Is it on the surface or intramedullary? That is with the question,
sir, I think it's extension in the it's extending in the medullary cavity
right? So, but bulk of the tumor is on the surface,
outside.
or
Yeah, but bulk is on the surface of the bone.
that's important, you see. And the other thing is, you see, you said this is all sunburst aggressive reaction, right? But look at the
Yeah.
cortex. There is a name for this morphology. What is this called when something kind of erodes the cortex on the surface?
Saucerization.
Yes, exactly. Good. Excellent. Yeah, this is called saucerization, right?
Yeah.
Or you can say just like scalloping. I mean, okay.
Okay.
And if you see on this image, if you see, obviously there is some kind of sclerosis here, but that could be just like nutrient artery or something. But in this region, if you see,
Yeah.
the endosteum looks quite clean.
Yes.
Obviously, there's nothing on X-ray is limited, but still looking at this, it looks like that the intramedullary segment of the bone is okay. And which part of the bone it is again?
Diaphysis.
Aphysis, yes. So it's a diaphyseal surface aggressive lesion in a long bone, right?
Yes.
Okay, so that's important, right? Okay, now I'm showing you, okay, I think these are stir images, but I think I'm going to go to this one. So this is pre-contrast, this is post-contrast for you.
Yeah. Oh, I could appreciate lesion and the mid diaphyseal region of the femur corresponding to the radiograph that is showing significant post-contrast enhancement. It is predominantly in the soft tissues. However, I could appreciate subtle post-contrast enhancement in the medullary cavity. However, there is no cortical breach. So, I think it is predominantly a soft tissue lesion, maybe a soft tissue sarcoma, as it is
Uh,
so much enhancing.
right, when was the last time you've seen a soft tissue sarcoma causing that much change in the periosteum? If we go
Mm.
back, the X-ray, I mean, look, we can look at this as well, but
Yes,
it's
yes,
kind of, it's sitting on the surface. All that cleft that we saw on the X-ray, that is because there is a
yes,
tumor sitting or arising from the periosteum, right? And then causing all
Outerly.
that kind of reactive change. Because
Okay.
osteosarcomas, soft tissue sarcomas can sit on the bone, but usually they don't induce this kind of aggressive new bone formation, isn't it?
Yes. Yes.
Okay, so I would stick to the guns. If you
Or
see a lot of periosteal reaction, new bone formation kind of thing, you have to think about primary bone tumor. And do
yes.
you know of any surface primary bone tumor? You said parosteal. Okay,
Yes.
parosteal is usually at the back of the femur, isn't it? And it's like a lump of bone, isn't it? This doesn't look like a lump of bone, like you said. This is quite large extraosseous soft tissue with bone. This is all bone inside it, right?
Yes.
And there's enhancement in a rind of soft
Um,
tissue.
as there's a large soft tissue component, um, I could think of Ewing sarcoma as they have as they have large soft tissue component, but they're also intramedullary as well. The periosteal osteosarc arise from inner layer of periosteum. The inner layer seems fine.
No, no, well,
Um,
hold on. Periosteal arises from the periosteum. It's usually on the surface.
yes,
So, I mean, because one thing, the simple thing is that anything that can arise in the bone, that can arise on the surface. Because
yes,
periosteum is the tissue that kind of forms the bone, right? When we
yes,
fracture,
yes,
then the periosteum kind of, there are osteoblasts there, they can transform and start putting new bone. So if you get osteosarcoma in the bone, you can get it on the surface. You can get chondrosarcoma in the bone, you can get it on the surface, right?
yes,
Just the morphology of it and the location. So this is because normally osteosarcoma, as you know, it's more metaphyseal, isn't it? Around the knee, or I mean, any metaphysis of long bone, you can get osteosarcoma. But this one is more diaphyseal and on the surface. This is typical location for periosteal
okay,
osteosarcoma. Yeah.
okay.
So don't go for inner and outer layer. We are radiologists. We're not pathologists, right?
Yeah,
I mean, periosteum is a matter of millimeters. You see, all
yes,
right.
okay,
So, but the key thing is, if you see, there is not much intramedullary happening.
yes,
If we go here, there's a bit of reactive edema probably
yeah,
enhancement, okay? But the epicenter or the bulk of the tumor is on the surface.
yes,
Okay? It's a surface osteosarcoma. And the
okay.
commonest one in this location, that will be your
Periosteum, okay.
osteosarcoma. Okay, next case now. Right, okay, I have got, I'll probably put both images there for you. This patient has got knee swelling. He's a 40-year-old guy, and he's got about 6-month history of knee swelling, on and off pain. Do you spot any abnormality there on these two views?
Mm. I'm looking at the radiograph, right, AP and lateral view of the knee, and I could appreciate that there is um, the tibiofemoral articulation. It's well preserved. Uh, I could not see any tibial spine or tibial plateau fracture. I could see mild irregularity of the patella on the AP view. Uh, however, I would like to confirm it on the skyline view or the MR. Uh,
Do you see any joint effusion?
yes, there is suprapatellar joint effusion, and uh, I could see joint effusion. Mm,
Okay, well, we got these MR images for you. So there's a coronal PD fat suppressed. There is an axial T2 and an axial T1 image there for you. So just describe what you see, please.
I could see a lobulated PD and T2 bright lesion uh, along the anterior and anterolateral aspect of the shaft of the femur involving the vastus muscle. I could not appreciate any cortical breach. I could not appreciate any intramedullary edema. The posterior fossa appears fine.
Periosteum. Do you see any
Uh,
periosteal response?
no, I'm not sure. I think, yeah,
So,
no, no,
so unlike the previous case, if you go back
no.
to the X-ray,
Yes,
X-ray is
yes,
clean. Yeah,
yes, yes,
all right. Okay, the mass is kind of bigger than probably previous one.
yes,
Yeah,
but there is
it's
no.
kind of on the surface of the distal femur.
Yes,
And as you said rightly, it's in the muscle. So it's an intramuscular thing, isn't it?
yes,
Yeah.
yeah,
This is the superficial layer of your cordyceps. This is the deep layer. And it's kind of it's abutting there, and probably if you look at the sagittal, there might be a bit of intra-articular extension as well, okay, which I'm not showing you here. Uh, but what do you think this is? Is this primary bone tumor or a soft tissue sarcoma?
Sir, I'm thinking it's a soft tissue one because the bone is clear.
Okay, right. Okay, let me
Or
show you a companion case to that. All right, and then this is another patient now. So yeah, so we biopsied this one, and this came back as soft tissue chondromyxoid sarcoma of some sort. All right,
okay,
all right. Now this one, this is a 20-year-old lady, and
okay.
she has got pain and swelling.
Sir, I'm seeing the radiograph projection, and I could appreciate that there is a mm, mild periosteal reaction along the lateral tibia, tibial cortex, and uh,
This is okay. I think that's projectional. You
okay,
mean this? I think
yeah,
that's
yeah,
just
this one.
that's projection. Ignore that.
Apart from that, the bones they seem fine.
Okay, what about the soft tissues then?
Uh, the soft tissues of the lower leg appears slightly bulky. Yeah, there is a large soft tissue mass involving the posterior aspect of the left knee. Uh, Still, I could not appreciate any definite cortical erosion. I could not appreciate any internal calcifications. Uh, I would like to correlate this with MR if available or ultrasound.
Said calcification. What does that imply? If you see calcification, then what
Soft
will you
tissue, it could be myositis or some calcified hematoma or calcifications. If there's a bone tumor, then they could represent chondrosarc, ring and arc calcifications.
okay?
Oh,
So that's
large
okay. So
mass.
this is there. This is post contrast.
Okay, I could appreciate a large uh, intramuscular, I think it's intramuscular mass that is bright on stir and it's not showing any significant post contrast enhancement. There's significant uh, edema surrounding and extending into the knee. I could appreciate mild edema in the shaft of the tibia.
Okay? These are axial images there. So T1, T2,
This one,
and this is
yes,
post.
on the T1 post contrast, I could appreciate mild post contrast enhancement on the T1 fat chat post contrast images, and it's low. I'm still thinking it's also a soft tissue lesion, not primarily a bone tumor.
Which soft tissue sarcoma can you think about?
Uh, Soft tissue sarcoma. It could be malignant fibrous histocytoma.
Do
If
we
the
use that
patient,
term anymore?
sorry,
We don't use the term MFH anymore, no?
yeah, the MFH. The other name is I think pleomorphic undifferentiated sarcoma.
Yes, yeah, UPS,
Uh,
yeah, okay.
yeah,
But this one is next to the
sy-
joint. So
yeah,
when something points, yeah, okay,
synovial sarcoma.
right, okay. So obviously
But
this would need to sarcoma center
sarcoma
and
center and biopsy, yes.
right, okay. What other when you're reporting this, there is one thing that the surgeon would like you to tell him. Okay,
Uh,
if I go to that image, do you, I mean, can you think of anything that is important for surgical, if for any surgical treatment if required, when you got
uh,
big mass?
I think the compartments that it's predominantly in the posterior compartment, the relation to the vessels.
Yeah, where are
Uh,
the vessels?
I could not see them clearly. I think they are a bit compressed and maybe lying anteriorly. Not sure. I'm not sure.
Well, you think
I
they'll
could,
be likely to be encased? Because if you look there, that's the vessel there, right?
yeah, but it's indistinct. Maybe it's encased within the mass.
Maybe or certainly.
So I'm not sure. I
Yeah.
want to, so in my routine practice, I would like to scroll the axial images and then
So let's
maybe
say
have
if
a better
if the
look
vessels
in.
are encased, you
Yes.
think this will be the limb can be salvaged?
I don't think so.
Right. Okay. How are we with time? Should we carry on or should we switch? Who is
Uh, I
coordinating?
think I think we should move to the next candidate. If we have time later on, so we can come back to candidate one.
No, great. I mean, I think candidate one, yeah, you did very well. Description was good, but just I think just try to be a bit more kind of concise that where it is and all that. Differential is always like aggressive bone lesion. Differential will be primary bone tumor, metastases, or infection, depending on the age. Obviously, if it's younger age, then you think about neuroblastomas and metastases. Well, yeah, or I mean, if it's 40 plus, you always think about myeloma. You'll always have to put myeloma if there's a lytic lesion. But yeah, I mean, this one was coming back to this one. This was a synovial sarcoma. Okay, when you see a
Okay.
large mass next to a joint with some calcification, I mean, I think 20 to 30% of them will have some calcification. So whenever I see a soft tissue mass next to the joint, not necessarily going into the joint, it just needs to sit next to the joint. Okay, it is it is a misnomer that it arises from synovium. It doesn't. It
Yes.
does not arise from a synovium. It is just that because next to the joint, it's a we call it a synovial sarcoma. Okay. The other one was periosteal osteosarc. The other one, the middle one, which without any bony change, was a yeah, chondromyxoid sarcoma. But it just when you see it, just I've just shown you a few things there. I mean, yeah. So depending on the age, the differential will change, and it can be a primary soft tissue tumor sitting next to the bone, or something arising from the surface of the bone, things like that. All right. Good.
Thank you, sir.
Thank you. Welcome. All right. Okay, let's have the next one. I'm going to show them. Okay. What about? Let me solve it now. I'm just going to come out of this PowerPoint. I've got all the cases, but I think let's just change the mood of it. So, right. I'm just going to let me put this image there. Okay, good. So this is a 26-year-old, and he presented to ED after a twisting injury to his right ankle. And that's the X-ray from ED that you're looking at.
Hello. Can you
Hello.
hear, can you hear me, sir? I'm candidate two.
Yeah, I can hear you. Did you hear what I said about this case?
Yeah, this is I think 26-year-old male who presented in emergency department with ankle twisting.
Yes. Yeah. Please go ahead then. Thank you.
Okay, this is X-ray right ankle joint frontal projection. There is slight thickening of the soft tissues along lateral aspects of the ankle joint. Besides this, I can appreciate vaguely defined area of lucency involving the distal metaphyseal region of the tibia. However, I will confirm it on the orthogonal view. The talus.
That's the orthogonal view for you.
The orthogonal view still this is vaguely defined. It could be projectional. Besides this, the ankle articulations seem to be intact. The talonavicular joint also.
Okay, that's there. Another view. They did a mortise view, so I'll keep it that on the screen for all of you. And then, yeah, you carry on. Do you just describe what you see, and then we move?
Yeah, I can see a small region of periosteal reaction along the distal metaphyseal region of the tibia in vicinity to this vaguely defined lucent area.
Periosteal where? On the lateral aspect or medial aspect?
On the lateral aspect.
Um,
In
I think
the
that's just
region of the interosseous.
I think this is okay.
And,
They're just projectional.
and again, there is soft tissue thickening along the lateral aspects of the ankle joint, lateral malleolus.
Yeah, that could be because of the twisting.
Yeah, it could be due to soft tissue swelling.
So if you're reporting this, how would you report it?
I will
You can.
suspicion of some soft tissue swelling along the lateral.
Well, that's probably every other ankle X-ray that comes from ED. They'll have a lateral ankle sprain, isn't it? So they get soft tissue swelling on the lateral side. But are you worried about the abnormality you described in the distal tibia?
Yeah, also, I think there is also some linear line involving the medial malleolus also. So this needs to be the lucency, region of lucency needs to be assessed further by cross-sectional imaging in the form of MRI of the knee involving distal tibia.
All right, okay. So, okay, I'll give you, I'll probably start with the T1 actually. So that's a T1 coronal. I mean, I don't know if I can give you the control. And let me see.
So I have requested remote control.
Approve. Okay, let's see. You can scroll. Oh, great. Okay, it works. Great. Okay, good. If you double click on it, you can double click on it. Good. All right. Yeah, just scroll through it for all of us for a few times and then we can describe.
I can see area of abnormal intensity involving the distal metaepiphyseal region of the tibia, right tibia. It shows slightly broad zone of transition along its lateral medial cortical margin, and also the abnormal signal intensity areas are also extending and involving the subcutaneous tissues.
Well, for that, you need to look at the axial, I think. All right. So we have seen the abnormality. Let's go to the axial. Okay. And then you can see whether the abnormality extends beyond the bone or not. Let's scroll through.
Okay. Yeah, definitely there is a slight wide zone of transition as there is extension of this region of abnormality.
Let me stop you there. For all of you, don't use the term zone of transition on MR. That's a sin. Zone of transition is the term to be used on an X-ray. On MRI, even very aggressive tumors will have they will be well demarcated from the normal marrow for the surgeon to cut above it, right? Okay. So don't use the term zone of transition. That is a no-no. So never use zone of transition on an MR. You can use it on X-ray. It's a well-defined lesion with narrow zone of transition or ill-defined with a wide zone of transition. That's fine. But never use the term zone of transition. No offense, but that's something I think all of you need to avoid, right? You can say, I mean, yeah, it's well-defined or ill-defined margin with the normal marrow. That's fine. But don't go for narrow zone of transition because that doesn't apply on MR. Okay, so now you can carry on. Please go ahead. Thank you.
So there is abnormal intensity signal area involving the distal medullary cavity of the distal metaepiphyseal region of the right tibia. There is a cortical thinning along the medial aspect, and abnormal intensity areas are also extending into the soft tissues. There is no region of hemorrhage.
This is post contrast now. All right.
Okay.
So let's look at that, and then you can give me the differential diagnosis. Then. Yeah. Thank you.
Yeah. I can scroll it now. So it appears hyper intense on contrast enhanced stir images. There is I can put differentials in this case. It could represent focus of osteomyelitis. Other differentials include giant cell tumor. The other differential I can put is some osteosarcoma.
Right.
So I
Why
will.
osteosarcoma? I mean, there is no bone formation there. You didn't see any aggressive periosteal reaction on X-ray. Osteosarcoma, I'll probably put as the last one. So the first three that you said were?
Osteomyelitis, giant cell tumor, um, and osteosarcoma. Other differentials include metastasis, but osteomyelitis I will put at the top.
The patient is well. His bloods are normal. He doesn't have any temperature. It's just
other
pain.
differential in this case would be metastasis. So I will.
He is 26-year-old. You think metastases will be on the top or primary bone tumor will be on the top?
Primary bone tumor, giant cell tumor.
Okay. Why do you say giant cell?
As the epiphyses in this case physes are closed and it is in the subarticular distribution.
Okay, that's good. All right. Okay. So what will the next step then?
I will inform the findings to the referring physician and also will refer this patient to the specific sarcoma MDT and for further decision of biopsy and further management. Also, I will ask for the chest radiograph if available, and also will ask for the previous imaging if available for comparison in this case.
Okay, good. Yeah, they biopsied it and it came back as Ewing sarcoma.
Okay, usually Ewing sarcoma, I think it is in the diaphyseal region, I think.
Well, it can happen anywhere. I mean, tumors don't kind of, it's aggressive kind of lesion with soft tissue, some necrotic foci as well. And it could be, I mean, if you look at the T1 for continue, I mean, I was with you. I thought this is osteomyelitis as well because you got some fat there at the top, right? And there was on the post-contact, there were areas of necrosis, probably liquefaction and all that. But it could be that the patient had a previous infarct or something. And then the tumor just went over it. Okay. So the tumors, I mean, they can be weird, but it needs a biopsy and it is biopsy proven. It came back as Ewing's. But you spotted it very well on X-ray, I must say. I mean, you look at there, but these are like, people say, is there a history of trauma? I mean, history of trauma sarcomas can present with the first position can be after trauma, whether this patient has been having some pain, hobbling on, and then he just kind of tripped off a stair or something. So trauma and tumor, they can interplay. That does not one does not exclude or or make you immune from the other. So that's just the point to keep in mind. Okay, next case now. I'm gonna pick that up. Give me a second. Okay, what's that? Yes. Okay. I get the plain film. It's always useful to start with a plain film rather than the other way around, but yes, I got it. Great. Okay, good. Right. Okay. So this is a 40-year-old and he's got severe leg pain. And this is an X-ray of his lumbosacral spine for you.
Okay, this is a X-ray lumbosacral spine frontal projection of 40-year-old male patient having history of severe backache. I'm looking at the lumbar vertebrae. The interpedicular distance is maintained. There is I cannot see clearly the left pedicle of the L5 vertebrae. However, I will confirm it on the orthogonal view. Besides this, there are areas of sclerosis involving bilateral sacroiliac joints, more on left side.
That is projectional. He is a man. It's okay. They ignore the sacroiliac joints.
Okay.
Okay, carry on.
So in the rest of the what we this is this I'm also looking some lucency along the left iliac blade. It could be some bowel related.
Yeah, that's a bowel loop. That's fine. Okay. Or that's polyprojectional. Okay, so before I show you the lateral X-ray, what do you think in a 40-year-old you have described and you have detected an abnormality and described it? What's your thinking? What's the differential diagnosis here then?
Absent left pedicle, it could be due to some um, there may be huge differentials in this case. It could be some mets, primary
There are
malignant.
there are not many huge differentials here. There are only 2 or 3 differentials, right? I mean, could it be congenital? That will be the first question we always have to think, isn't it? And what? Sorry, say it again.
Absent pedicle, congenital.
But if one is absent, the other gets hypertrophied, isn't it?
Yeah.
Yeah, the other looks normal, isn't it? Yeah. All of you can see it, I hope. Yeah, I mean, you spotted it right straight away. That's good. So always, I mean, and you'll be surprised in your normal practice when you are reporting X-ray at your workplace. You don't, I mean, it doesn't kind of come, but I mean, you look at it and then you sometimes if you look harder, then yeah, it's there. But we tend to, it's always good practice to look at the pedicles. I mean, I don't know. I mean, I might have missed a few of these, but yeah. So it's not there. So what's the 2 things in somebody 40-year-old? What are the 2 differentials you'll be thinking about?
It could be as their contralateral is hypertrophied, so it could be congenital. Other differentials include mets.
Okay, right. Okay, this is the, sorry, I'll just put it there for you. So that's the lateral X-ray. Describe what you see there.
In this lateral lumbosacral spine X-ray of the same patient, I can see abnormal lucency, region of abnormal lucency involving the whole of the L5 vertebral body, and also involving the anterior and the posterior element. This is extending and involving the pedicle of the same vertebrae. So I will confirm. I will confirm it on the MRI. Also, I will suggest MRI of this patient to further
So
delineate the
what's
abnormality.
about, is the spine quite straight?
There is slight straightening of the curvature of the lumbosacral spine. It could be due to lumbosacral spasm, as
He's in pain. I told you he's in pain, isn't he?
yeah. This is due to
So
straightening of
which leg the pain would be in?
in the left leg.
Yeah, okay, in the L5 distribution, isn't it?
Yeah.
All right, okay, so you said let's get an MR. All right, okay, I'll give you the MR. Right, okay, so this one. Second. Okay, we did an MR in the morning. Okay, so this is, yeah, this is a T2 weighted image there for you. You can scroll probably.
Yeah. You can scroll it. So definitely there are regions of abnormal intensity involving whole of the L5 lumbar vertebrae. These are also causing pathological fracture, and these abnormal intensity areas are extending along the posterior elements, posterior corner of the vertebral body, and involving the posterior elements. So suggesting it's a malignant nature. It could be due to.
Okay, let's look at the stir because I think it's a bit difficult to see on that T2. I'll put the stir for you just a second. So let's put the stir here and the axial. Do you have an axial T2? I have axial T2 for you. Wait, axial T2 there. And sagittal stir, I'm gonna put it in there. Okay, just a second. So let's do bolt. All right. So now if I magnify this for you, all of you, okay, You want to just, okay, there you go. So I think, yeah, now if you scroll, please, on the sagittal first. Oh, yeah, okay, fair enough. You can see there. All right. Okay, yeah, keep that image there. Yeah, yeah, that, okay, okay, that's
Okay.
a good image.
So, yeah, this abnormal signal intensity area, this also has a epidural component, and it is causing mass effect on the central spinal canal. Also, there is lateral foraminal. This is also encroaching the lateral foramen and the exiting the roots right over here. First, I will urgently inform the referring physician about the finding to decompress this lesion and to relieve the patient from pain, as there is also mass effect on the lateral foramen and the exiting roots. Then I will suggest the referral to the specific sarcoma, MTT. Also, I will suggest staging CT to look for primary. Also, will like to see the chest radiograph of this patient to rule out metastasis to the lungs.
Chest radiograph is normal. So the differential we need to see, one, you said metastases. If I say it's a primary bone tumor, which primary bone tumor can affect the vertebral body like that?
Aneurysmal bone cyst or...
Well, do you see any fluid levels on the T2 weight?
No, I couldn't see a chondroblastoma.
So this T2 signal, is it bright T2 or is it low T2?
It is slightly low as compared to normal CSF.
Right. Okay. So what does that imply? Can you be a bit more clever and give a more pertinent differential diagnosis there? In addition to metastasis, it's not metastasis, it's a primary bone tumor.
It could be brown tumor, could be some aneurysmal bone cyst or giant cell tumor or some chondroblastoma.
I mean, exam is not about kind of naming the tumors that come to mind, right? Okay. So you need to, yeah, aneurysmal bone cyst, we said there is no kind of fluid level. I mean, that's a good thought because aneurysmal bone cyst can involve the body, particularly it involves the posterior ilium or the posterior elements. This one is primarily a body tumor, isn't it? It involves a tumor. And if I had said this is a 60-year-old, you would have said metastasis, myeloma, lymphoma, isn't it? All of you. I mean, myeloma probably is like a plasmacytoma if it's the only kind of single lesion there, right? But when it's 40 or less, then it's a giant cell tumor. I don't know, you might have not seen a giant cell tumor in the vertebral body before, but we have giant cell tumors typically, when we think about it, comes as mind around the knee, subarticular, distal femur or proximal tibia, but they can involve the vertebral body as well. This was biopsied, it came back as giant cell tumor, and that the patient had it removed, and I'll show you the post-surgical X-ray there. So the patient, do you know what operation the patient had? What is this called?
Vertebroplasty.
Is it vertebroplasty?
And also bone grafting.
They have taken half of the vertebral body out, because you see,
Telegraph.
if you see there, that's the transverse process on the right. The left side all was tumor. They had to scoop all out. There was nothing left. So they did what we call a corpectomy. That when you take the vertebral body out, it's called corpectomy, and then you put this. So yeah, that was, and if you look here, look at that. This is the transverse process, the iliolumbar ligament there. And this whole thing, the tumor is going all the way down there. I mean, it has got epidural spread, but the caudoecardial nerve roots are not corroded. All right, it is causing significant encroachment into the foramina because, and then that's causing pain. Yes, but we did the biopsy first because it could have been osteosarc or Ewing's or anything more sinister or more kind of aggressive than a giant cell tumor. But the giant cell tumor is locally aggressive tumor, so we biopsied it under CT. I'll show you the CT as well, just to give you an idea how on CT it looks like. And there, you see. So again, so whenever you see a large lytic lesion in the vertebral body or in the sacrum, in somebody 40 or less, always think about primary bone tumor, i.e. giant cell tumor. Okay, next case for you, I'm gonna bring up just a second. Okay. So let me close this. That's okay. You did so much good on the ankle. I'm going to show you this ankle now, the last case for you. So this is a 10-year-old, and he has got a few month history of atraumatic ankle pain.
Okay, this is a lateral radiograph of the ankle joint of a skeletally immature patient. I can appreciate a diffuse area of haziness involving the anterior and posterior aspects of the ankle joint um, and into the soft tissues surrounding the ankle joint. Also, the bone density is also reduced, especially involving the calcaneum. In the visualized tibia and the fibula, there is no gross abnormality. This area of increased haziness involving the soft tissue surrounding the ankle joint.
Increased haziness. Yeah, okay, fair enough. The soft tissue haziness. Yes, all right, good. That's good. So always look at the soft tissues. What about the bones? You see any abnormality in the bones or joints for that matter?
Yeah, in the calcaneum, there is a relatively reduced density in the calcaneum, also irregularities along the posterior calcaneal surface.
This is normal. This is
Okay.
within normal. Okay.
I will also like to see on the orthogonal view if available for.
All right, sure. That's the orthogonal view for you.
Yeah, again, there is soft tissue thickening and haziness in the surrounding soft tissues. Besides this, in the talus, if it is projectional.
So if this patient presents to you, right, and you're reporting this, what's the next kind of investigation you would advise? Obviously, everybody
As this is
will go for MR, but is there anything else that you can do? Let's say out of hours, if the patient presents to ED and you are on call and this X-ray comes to you, then there is one kind of cheap test that you can do, isn't it?
there is
What that
also
will be?
some lucent lesion surrounding sclerosis in the talus.
Which part of talus?
In the neck, in the region of neck of the talus.
Okay, right. Are you sure about that?
I will do ultrasound in the emergency
So
department.
what will ultrasound tell you? I mean, what are the two things that ultrasound will be able to differentiate?
This will give very clear picture the soft tissues in the surrounding joint, ankle joint, and also.
So you will be able to identify if there is an ankle effusion, or and then if there is any synovial thickening with marked increased vascularity, i.e. synovitis, isn't it? Because the two things you are thinking about here is what? What are the two differential on the basis of this X-ray?
The soft tissue thickening in the surrounding the joint. This is likely favoring the joint effusion, and
can you think about any joint pathology that kids can get?
Synovial, in the any synovial osteomyelitis or synovial sarcoma.
I mean, one is septic arthritis because there is so much kind of soft tissue thing there, right? What else kids can get? You can have inflammatory arthropathy, JIA. You can have juvenile inflammatory arthropathy. It's not that uncommon. Okay? Yeah. So always think about whether, I mean, when you see things around the joint, you have to think, is it in the bone or is it in the joint? And the joint can get infection, can get inflammation. You can have they might have a UTI and they got reactive arthritis in that ankle. Or this might be the first presentation of somebody who's got juvenile inflammatory arthropathy, like child onset kind of rheumatoid arthritis. Yeah, it's not that uncommon. I mean, if you work in a place where you see kids, every month you're going to see a child with swollen joints, and JIA is in the differential. So, okay, well, that's by the by, but let's go on. I'll show you the MR. Okay, so obviously, okay, wait, let me, there. All right, you can scroll. So this is a non-contrast sagittal stir.
Yeah, it is showing the joint effusion, moderate amount of joint effusion, abnormal severe intensity areas involving the talus. The X-ray also was showing relatively reduced bone density. So again, I can put the differential of septic arthritis and juvenile idiopathic arthritis.
Okay, let's look at that image. All right, sorry. Okay, I've ruined it a bit. You said septic arthritis. That's obviously that will be in the differential, but there's one thing. Which side? I mean, if let's say this joint is full of pus, right? So the edema, you will get marrow edema on both sides, isn't it? Over here, where is the epicenter of the marrow edema? Where is the marrow edema here?
This is in the center of the medullary cavity.
You know, which bone?
The talus.
Yeah, so it's on the talar side, isn't it? There's no marrow edema on the tibial side.
Yeah.
So, I mean, it could be early septic arthritis that a patient has got early changes in the talus, but somehow the tibia has been spared, which is odd, because I told you it's few month history. So yeah, so this is the T1 weighted image now. Any thoughts about that? You saw some sclerosis, so the changes that you saw on X-ray, they get confirmed here, isn't it? That you have got T1 isointense signal, but there is all this edema around it with this T1 slightly, I mean, the T1, this is more like edema signal on T1. This area is a bit more dark. Then, okay, somebody said get a CT. So then you can scroll the CT and give us the diagnosis then.
Again, there is relatively reduced bone density and
let's go to the area of concern. Don't look at the whole thing yet. Just go to the area of concern. That's the calcaneum. We need to look at the talus. Keep coming. Yes, just stop there. What do you see there?
there is a region of lucency with surrounding region of sclerosis, and the region of lucency shows internal region of hyperdensity. So it could be osteoblast, osteoid osteoma or osteoblastoma.
Okay, if I put this, there we go. So yeah, so let's just get to that image. Sorry, there. So yeah, so what's the difference between osteoblastoma and osteoidostoma?
Osteoblastoma is more than, if the osteoidostoma less than 1 to 2 centimeter, and if this is more than 2 centimeter, it is.
It's the size, isn't it? It's the size. So if the lesion is small, it's called like this. This is a typical morphology of osteoidostoma, right? And this is what we call a subarticular one, okay? So because these are inflammatory tumors, this one and chondroblastomas, when they are next to the joint surface, they cause a lot of reactive edema, and you can have a reactive joint effusion. So whenever we see somebody, particularly in young, 20 or less, with kind of joint effusion, and then the features are a bit atypical, you always have to think about, could this patient have got a subarticular osteoidostoma, right? And obviously the history will be, there will be typical features of night pain and relieved by ibuprofen and things like that. But the key message I would give you here is, whenever you see soft tissue swelling around the joint, then if you get inflammation on both sides, then you can think about inflammatory or infective causes. But when it's primarily involves one bone with relative sparing of the other bones forming the articulation, always think, is there something happening in this bone that is causing this? Which could be osteoid osteopenia. It could be a Brodie's abscess as well, right? But that would usually be a much more fluid and kind of, and more like there will be a bit more kind of fluid in it. This one is more sclerotic, and CT appearance is very pathognomonic of osteoma. So this was biopsy.
Also, it was obvious on the X-ray. I mentioned the neck of the talus.
Once it's obvious, I mean, well, I mean, yeah, I mean, it's obvious, obviously, in the exam setting or in retrospect. But the key findings, I think you picked up very nicely on X-ray. One is the soft tissue swelling, and then that was sclerosis, right? So then soft tissue swelling. I mean, if I'm reporting this X-ray, I think this is JIA or effusion, and then this one, I mean, this could be osteomyelitis, or I mean, I wouldn't have said this is osteoma on an X-ray, yeah, but. Then obviously the MR, when you see the MR and you can differentiate the marrow edema affecting the talus more than with no edema on the other side, then infection.
Hello. Hello.
Not have seen before in your day-to-day practice. All right, let's move on. Candidate 3, then please.
Thank you, sir.
Any questions? I mean, before we get somebody.
Assalamualaikum.
Walaikum salam. All right, okay. We can leave the question to the end probably. I mean, I've got 4 candidates, isn't it? Irfan? Okay, let me share the screen. So multiple participants can share simultaneously. Yes. So I'm going to share this. Okay. So I hope you can see the screen.
Yeah.
Yeah. All right. So I have got a 35-year-old prisoner, and he presented with worsening left knee pain and swelling. And
Okay.
you're providing the radiographs now.
Okay, so I've been presented with frontal projection of left knee joint of prisoner who have pain in the left knee joint. So here I can see that there is motor sclerosis or patchy sclerotic area, which is involving the proximal tibia and also extending over the distal femur. And there is also periosteal reaction, which is involving the bilateral margins of the tibia. And yeah, so I can see that there is a wide zone of transition, and there is soft tissue component, and there is which is more marked along the upper distal half of the medial aspect of the left femur. So in my routine practice, I will check the orthogonal view to check the soft tissue component and the presence of any calcification. So here I can see that these patchy sclerotic areas are involving the visualized part of the tibia and part of the fibula with significant soft tissue swelling, which is extending suprapatellar region within the joint space and posteriorly. I'm looking for the presence of any calcification. So here I can think that there are few ring and arcs calcification are also present within the soft tissue component. So so I'm thinking in line of synovial osteochondromatosis in this case. So I will check any previous radiograph if available of this same patient. The other differential in this case could be chondromyxoid sarcoma. So further evaluation is recommended in this case with MR.
Right. Okay. You said synovial chondromatosis, right? Okay. What is something very characteristic of synovial chondromatosis that you are not seeing on this X-ray?
Yeah, we can see that there are calcific densities which are present within the synovial. So I cannot see, but there are ring and arcs. So
where are rings and arcs? You mean there, is it?
yeah, within the joint and also in the distal aspect of the femur posteriorly.
Yeah. So this is all this abnormality there in the synovium.
Yeah.
Goes in Topher's fat. You said rightly. It goes back as well, right? So is it a joint-based problem or a bone-based problem, or both?
It mainly sorry, it's mainly soft tissue, but it's also involving the bone. As we can see that there is periosteal reaction which is involving the proximal tibia.
Right.
So it may secondarily involve the bones, but mainly it is soft tissue.
Okay. I'm going to show you the CT now, actually. We did a CT because the patient was claustrophobic and we couldn't do...
Okay.
Wait, let me get you a CT right over here. Yeah, all right, okay. So you can, wait, let me see, we can scroll. This is...
I have requested the note.
Yeah, I will let me just get you the right one, because sometimes if there are too many, just hold on a second. Let me get you soft tissue. That one. I'm gonna jump actually. Wait. What about this one? No. Wait. I think I've got it. This one might be. So that's the distal leg. Okay, let's go into the distal leg though. We need the proximal leg. So if this is still 40, and then probably if I go on this one. Yeah, that might be this one. Yes, just a second. I've clicked on that. Let me scroll it for you, because I think it might be
Okay.
yeah. Okay, no, well, okay, you can scroll now. I think it will be there quite a lot of images. So just scroll slowly. Let's see. Or if it's not working, I can scroll for you.
Yeah, I can scroll. So here I can see that there is soft tissue thickening within um, showing enhancement, and
this is a non-contrast. This is a non-contrast.
Okay.
You cannot see
So
any contrast in the vessels there.
No, yeah. So here I can see that there is significant soft tissue high density area which is present anteriorly. It is showing a central low density linear area within it. There are areas of calcification which are present. Can we a little bit zoom up the image so I can see the calcifications? Yeah. Thank
Do
you.
you still think this is synovial osteochondromatosis?
This is one of our differential. The other differential could be a pardon?
Yeah. Which other differential would you go for?
Chondrosarcoma is my other differential.
Chondrosarcoma affecting the joint, the synovium, is it?
It's less likely, but just trying to look at the bone. Can we have a shift to the bone window?
There you go.
Okay. So there is some irregularity or erosion of the bones also. So this more likely to be a synovial osteochondromatosis.
Okay, just hold on. Let's pause there. And then somehow we did the ankles as well, actually. So I'm just going to show you the ankles now. So if I go down, we're going down, all right?
Okay.
Yeah. I keep on jumping, but let's see. I hope we get to the ankle. Loading up this one. No, I don't have the ankle, but I have got the. Okay, what about if I show you the ankle X-ray? Or the foot X-ray for that matter.
Okay.
So that's the foot X-ray for this guy.
Okay, so I've been provided with foot, a right foot of the same patient. So here I can see that there is a same density, soft tissue density, which is involving the metatarsophalangeal joint of the second finger with there is erosion of the distal neck of the distal metatarsal of the same finger. There is also erosions involving proximal phalanx, base of the proximal phalanx. So my differential in this case could be an agouti arthritis, or this could be a septic arthritis.
Septic arthritis with multifocal involvement, yeah. You can have it, I'm not saying you can't have it. But how can you confirm it?
So we can aspirate fluid and check the urate crystals. So this may confirm our findings.
I'll show you the ultrasound picture there.
Okay.
Let me go up there. So that's that's the foot there, but the knee. Look at the left knee there. I want to show you. I mean, the thing is, when you got these big chunks there, you see that?
Yeah.
It's like I think posteriorly.
Yes.
I want to show you the superficial approach if I can. So yeah, this one kind of. Sometimes it's very difficult, right? I mean, all of a sudden,
yeah, this seems to be thickened synovium, which is filling the articular surface instead of a free fluid or joint effusion.
So we aspirated about like 30 ml of milky fluid from the knee. So what is this? This is the CT we did.
Dual
for
phase
Gout.
CT.
So, and it's all showing you these big lumps of intra-articular and juxta-articular lumps of sodium urate. Do you know the name for this study? What is this?
This is dual phase. Sorry.
Dual energy CT.
Yeah, dual energy CT.
Okay, so yeah, this was Gout. So when I put the X-ray back for you, the knee X-ray. I mean, fair enough. I mean, you can say some kind of synovial process, but synovial osteochondromatosis on the basis of exposure on CT, it might be because it's kind of very calcified and lumpy bit. But here, I mean, again, it's hyperdense, yes. I mean, you can see the whole extent of the abnormality. But synovial osteochondromatosis, you can say some synovial pathology. I think that's probably a better term. Because synovial osteochondromatosis is something different, all right? Okay, I'll put the next case up for you.
Thank you.
So yeah, that was gout. All right, so prisoners, elderly, gout can present in different forms. Okay. All right, I have got there we go. So this is a 40-year-old and she got bilateral shoulder pain. I'm gonna put, wait, I'm gonna put probably both shoulder x-rays for you actually. Just for, let's see. Okay, fair enough.
Okay, so should I start?
Yeah, please go ahead. Yeah, you can start with this. Yeah.
So I've been presented with frontal projection of the right shoulder joint. So of a patient who have bilateral shoulder pains, where I can see that there are areas of calcific density which are present intra-articularly, and it is causing slight extension over the upper proximal part of the humerus. It is also extending toward the acromioclavicular joint or distal to lateral part of the clavicle, and the bones appears unremarkable. I cannot see any periosteal reaction or irregularity of the articular surfaces. There are these calcific densities shows peripheral hyperdense areas with central lucencies. So again, I'm thinking of synovial osteochondromatosis. The other possibility could be a tuberculous arthritis. So I will check.
Why tuberculous arthritis? The joint is fine.
Yeah, so okay. So the other possibility could be tumoral calcinosis, but it is less
Is
less
it in the
likely.
joint?
Yeah, it is around. It's on the extensor surfaces, basically. So
Let me show you the MR then. Why don't you scroll it for us?
okay. So we can see that there are multiple low intensities, well-defined areas within the synovium, and they are extending into the subacromial bursa. Basically, they are present within the periarticulars. I can see
Are they in the joint or in the bursa?
they are looking in the bursa.
So your differential is going to remain the same or it's going to change? That's the leading question.
Synovial osteochondromatosis is my top differential in this case.
But they're not in the joint.
So then the other differential in this case could be.
No, you are right. You're right. Sorry, let me get you out of your. I mean, because this is like it's a form of synovial metaplasia, right? Okay. So it can happen in any synovial line structure, whether it's a synovial joint or it's a synovial bursa, right? So it's just the synovium somehow undergoes metaplasia, forms these osteochondral chondral metaplasia, and they shed off, right? So this is in a synovial structure, right? This is synovial osteochondromatosis affecting the subacromial subdeltoid bursa. That's fine. Yeah, because they're well defined, kind of numerous kind of variable size, but they're well defined kind of osteochondral bodies with relatively preserved
Recording
joint space,
stopped.
Right? So,
Recording in progress.
can you hear me?
Yes, again.
Yeah, so I mean, you can have it even in adventitial bursa as well. This is a large bursa with synovial metaplasia. So this is fine. This is synovial osteochondromatosis in the bursa. That's all. Yeah. All right. Okay. So remember, I mean, you can have. I mean, obviously, when you think about synovium, you think about the joint, but synovium is around the tendons. It's in around the bursa and all that. Bursa and tendon, they're all synovial line tissues. So it can happen. The same pathology can affect synovium anywhere. Yeah. Okay.
Yeah. Thank you.
So this is what typically looks like synovial osteochondromatosis. Yeah.
Yeah.
All right. Okay. Okay. Let's pick one more for you. Show you this one. Let me close these. I have got a young lady and she has got hip pain. And I'm going to show you a pelvic. Some of these horrors thing, I mean, the things you click on something and the the case that you want to show goes in the background. Just bear with me. Okay, well, let's go to probably other one. I think talking about. No, okay, well, I'm changing the case now. I'll put this case up for you, and I'm going to give you the MR first. So I've got this colleague who is a nurse in my hospital, and he had severe hip pain. He was limping. And I'm going to show you the MR that he had done elsewhere. So wait, I'll probably put the axial star for all of you. Okay, you can scroll if you can, please.
Okay. So I've been provided with T2 Frcr or star images of the patient who have hip pain and limping. So I'm going back to the area of interest. So here I can see that there is significant altered signal which is involving the anterior inferior iliac bone just above the acetabulum with the soft tissue edema in the adjoining soft tissues. There is slight joint fusion is also present within.
Okay, let's look at the other plane. Let's put the coronal up. Sake of time. Let me just window it for you guys. Okay, just scroll through there now, thanks.
Again,
So
I
the
can
abnormality and
basically it is involving the acetabulum and the adjoining part of the iliac bone, and is also standing into the slight soft tissue edema in the surrounding soft tissue.
okay. Let's just look at, I'll just keep that image, this image there for all of you, right? Okay. So, yeah, so what else do you see on that image?
There is a soft tissue component which is present medially, I guess, yeah.
Okay, well, let's make it probably a bit easier. I'll probably put a sagittal up for you. All right, there's a sagittal star you can scroll through. That's the greater trochanter, all right, going to the femoral neck, to the femoral head.
There are altered signal which is involving the head and neck of the femur, and also
That's normal. I mean, on that image, you tell me, is the problem in the joint or in the bone?
it's in the bone.
Good, which bone?
This is mainly the iliac bone.
Iliac or acetabulum?
Yeah,
Acetabulum,
sorry,
isn't it?
acetabulum, yeah.
Okay. So there, if I show you that image, okay, so the epicenter of it is in the anterior inferior iliac spine, as you said. Okay, what is this structure then?
This is sartorius.
Sartorius comes from the anterior superior, isn't it?
Oh, okay, so rectus femoris, I guess.
Yes, okay. So it is at the rectus femoris attachment, isn't it?
Yeah.
Yeah. So what do you think it is then?
So this could be traction trauma.
Okay.
It may cause traction tendinitis and involve edema.
There is
If
no
I
history
can.
of trauma, but okay, that's a good thought. So we thought, okay, let's do a CT then. All right.
Okay.
So I'm going to put the CT up for you. I mean, we said that if you see marrow edema, always think, is there a lesion in the bone, or, but, and especially if there's a joint effusion, think about, is there osteoma or anything like that. But this one is not in the joint. There's no joint effusion. It's all anterior to that. There all this altered signal in the soft tissues, and the big tendon attaches there. So obviously, avulsion injury will be in the differential. Okay, so I'll put the Okay, what about if I put, okay, well, let's start with the axial, I think, isn't it? Axial will probably tell us is there a revulsion or not. And if, okay, yeah, you want to scroll?
Yeah.
All right, okay, we're going up now. All right. Yeah, can you scroll or should I?
Yes, I am scrolling. I don't know. Am I going up or down?
Go the other way. Go the other way, please.
Okay.
Well, you have to probably scroll. Let me scroll it for you because I think
Okay.
the images are more. So let me get to, all right, so that's the lesser trochanter. Let's get to our area of interest. So femoral neck. Yeah.
So yeah. So there is calcification which is involving basically at the insertion site. So this could be a myositis sort of thing, like myositis of skin. As I can see, this is peripheral calcification instead of central.
Okay. But does it look like typical of an emulsion injury to you?
No, because
The
I
history
can
is
see
quite
that
acute.
because there is an expansion at the site of insertion, and there is erosion of the.
Yeah, there's an erosion. Yes, good. There's a bit of periosteal reaction as well, if you see here. Yeah.
Yeah.
Yeah, but that's just probably just a reactive change. But what about these amorphous, dense kind of densities there? Any thought?
Uh,
You
I'm
must have
thinking
seen
in
it
line
around the
of.
shoulder.
I'm thinking in line of myositis ossificans.
No, myositis ossificans will be in the muscle. No? This is in the region of the tendon. We talked about tendon
Okay.
emulsion injury, right? Okay, fair enough.
Right.
That's a
Okay.
possibility still. Okay. What other process you can think about, an inflammatory process that can affect?
Tendinitis.
Yes, well, okay, fair enough. That's easy, isn't it? But which form of tendinitis?
Synovitis due to some inflammatory.
There you go. Okay, so I'm scrolling that for you. So this is the straight head of rectus femoris, yeah?
Yeah.
And as I come forward, I see some calcification in it. So what is it? If I show a shoulder X-ray with this calcification, patient is severe pain, what would you say?
Calcific tendinosis.
Calcific tendinitis, yeah. Okay.
Yeah,
So
sorry.
yeah, this is calcific tendinitis of rectus femoris. That can present. I mean, these calcifications usually kind of go out, but they can go into the bone as well, causing these kind of reactive like introsseous extent with lot of like lot of osteitis. This is all chemical, sterile kind of process. Okay, this is all calcification going in this black stuff. I mean, this could be gout, fair enough, but this is like calcification, which is just causing all that reactive change. And I say that because I'm going to show you the MR after 4 weeks and look what has happened. So it is much better. You see, it hasn't got worse. The patient, all he had was just some probably naproxen or something like that. And within 4 weeks, look at the degree of, look at that calcification, that's gone. See?
Yeah.
Calcification is gone. That edema is still there, but not as florid as it was when it started. So whenever you see a tendon, whenever you see edema next to a major tendon insertion, think about trauma, like you rightly said, but also think about calcific tendinitis. And I'm going to show you the X-ray, which we didn't kind of talk about. But there you go.
Yeah.
So it looks like a coffee bean. It doesn't look like a typical avulsion fracture that you see in adolescence, right? Okay. So think about calcific tendinitis. Okay.
Yeah.
It can happen here. It can happen around the trochanter. It can happen around the wrist. Commonly, we see it around the shoulder, but we can see it elsewhere as well. Okay.
Easy to comment on the X-ray than on MR.
Yeah, that's it. So wherever you're in trouble, get an X-ray.
Yeah. Thank you.
All right. Okay. Good. All right. Great. Okay. Let's get the last one, please. Thank you.
Okay. Thank you.
Okay. joints. You see, these are like common pathologies, but I'm just showing you at atypical locations. That's all.
Yeah. Yeah. Thank you. Nice case.
No problem. Thank you. Okay, let's get some things for you. Okay. Somehow it's all the knees that I'm getting, so which is probably good. I think if you think about, if you look around one joint and you see different pathologies, you can probably remember it, and then you can apply the same things on other joints. Okay, so I'm gonna just put this X-ray for you. Again, these are real cases which I have came across over the last few years. Okay, so I've got this 40-year-old guy. Wait, there we go. Sorry. Okay, so this is a 40-year-old laborer, let's put it that way. And he presented with few-month history of worsening knee pain and swelling. And he presented with a limp. So this is a lateral X-ray. Let's start with the lateral X-ray, and then I'll show you the other one.
Okay.
Do you see any abnormality there on the lateral X-ray?
So I've been presented with lateral projection of the knee joint rotated with semi-flex position of a laborer. So here I can see that there is like increased density in the infrapatellar region of the right knee joint. So yeah, so there
When you say
is
increased density, what does how do you notice increased density? What you're not able to see?
so normally we can see the fat density here, but it is more than the fat density. That's why I'm thinking in line of there any soft tissue pathology which is present in the